voice, Chester B. McVeigh of the University of South Dakota School of Medicine.
I am constantly amazed at the continuing interest in the ubiquitous groin hernia. The members of this panel I know well and have known them for a long time, and I think you'll find there is no difference of opinion in basic principles. There's difference of opinion regarding technique. I think this is fundamental to the problem of the groin hernia. And basic is the small time spent anymore in the study of gross anatomy. A cadaver is frequently not the best place to learn the anatomy of the inguinal and femoral region. The next step along the line where a fault may lie, no fundamental training in the technique and art of hernia repair. So many times errors are compounded, and I can tell you from long experience, it is very difficult to correct a basic fault in knowledge in this regard.
And to elucidate for us now the gross anatomy and techniques of hernia repair are four knowledgeable surgeons: Lloyd M. Nehus of the University of Illinois College of Medicine, Joseph L. Ponca of the Henry Ford Hospital, Francis C. Usher of Baylor University College of Medicine, and our program moderator, Chester B. McVeigh. This week's edition of Audio Digest Surgery, Volume 16, Number 18, for the week of September 24th, 1969, was recorded at the 118th Annual Convention of the American Medical Association. And to begin our look at the surgical management of groin hernias, here once again, Dr. McVeigh.
I'd like to introduce the first member of the panel, Dr. Lloyd Nehus of Chicago.
As you know, I have been interested in the preperitoneal approach and iliopubic tract repair for groin hernias for some 10 years, and my presentation is some of the anatomy of the posterior inguinal wall. It's my belief that everyone, no matter what type of repair they use, should be equally knowledgeable about the anatomy as seen from the posterior wall as from the anterior approach. And I'm afraid that this point is not universal in America or the world today. The key, as we believe it, is the structure, a thickening in the transversalis fascia layer called the iliopubic tract. This is not to be confused with the inguinal ligament. It is, in my opinion, a strong structure. It relates to all types of groin hernias, the direct, the indirect, and the femoral. This structure is what we talk about using either from the anterior approach or the posterior approach in the repair of these hernias. Well, I wanted to set one thing clear. It is my profound belief that the femoral hernia should be approached only from the posterior approach. It's so much simpler, and it's so simple to repair. That's my only brash statement for today. We are believers, as the panelists, that the important aspect of groin repair relates to the posterior inguinal wall, and that in general, any type of repair which relates to the inguinal ligament is sort of icing on the cake and is probably not necessary. One of our points is that from the posterior approach, you don't have to fool with cremaster muscle, and indeed, if you're going to do an anterior approach, cremaster muscle, in our mind, must be excised so that you can truly see the transversalis fascia layer for the repair. It is our belief that much of the confusion in the past in anatomy has been the dissection of the pickled cadaver, as it were, and that any of you who want to study the anatomy of the posterior inguinal wall should go to the autopsy room and dissect this area. Unfortunately, many people do not do this. They try the approach without having studied the anatomy, and they get confused, and they get recurrences. You see Cooper's ligament, the femoral artery and vein, the internal ring, Hasselbalch's triangle, and the thickening, which we call iliopubic tract, a structure that was first described by Thompson in the early 1800s. The thinned area of Hasselbalch's triangle is where we have the direct hernias. The arch of transversus abdominis is usually taken down to Cooper's ligament in the McVeigh or Lothiasen repair. We believe that the repair using these tissues is about 1 or 2 sutures different than the classic McVeigh repair, in that the first sutures between the arch and Cooper's are the same, but that we start walking out on iliopubic tract 1 or 2 sutures before Dr. McVeigh would put in the transition suture moving up to the anterior femoral sheath. For the repair, using these structures of a femoral hernia from the posterior approach, the femoral sac going out through the femoral canal. I should state at this time that we always excise femoral sacs because they often have a scarred narrow neck, which if you left in the body might cause a strangulation subsequently. We do not ligate the inferior deep epigastric artery and veins as a routine, but occasionally it facilitates exposure. Then the placing of the sutures between anterior femoral sheath, or as we call it, iliopubic tract, and the completion of the repair with 2 or 3 sutures closing this defect. Of course, if it's an incarcerated femoral hernia, one that causes all trouble from the anterior approach for fear of damaging the vessels are on direct visualization. It's a simple matter to free the incarcerated hernia by incising iliopubic tract at its insertion and freeing things up. You're right on the peritoneal cavity. If you need to resect bowel, again, there's no real problem. Griffith of 1959 article in the Surgical Clinics of North America makes a point that I like to make about Dr. McVeigh. When I was brought up in the surgical residency, we tore down more good posterior inguinal walls just to do a, quote, McVeigh repair. Well, of course, this was wrong. Dr. McVeigh does not do a Cooper ligament repair for every case. For the small indirect hernia, he does a high ligation of the hernial sac and does a transversalis fascia plastic repair of the internal ring, and does not, in this setting, tear down this nice posterior wall, which is perfectly satisfactory.
The next speaker will be Dr. Ponca of Detroit.
My approach to the repair of hernia is tempered largely through the type of clientele I have, and it consists mainly of elderly gentlemen who are employed in the various factories of Detroit. This would make the type of hernia problem somewhat different, for instance, that you would encounter, say, in a hospital where the clientele is, say, largely of the pediatric age. Now, these are practical points to remember. No matter how you look at the subject, the one inescapable point is that there is a hiatus that is abnormal, and it must be corrected by one method or another. Since you don't put something into the area of repair, it means that you are shifting something. So then you are bringing tissue from its location to another location to a degree. Now, in an indirect inguinal hernia, you will hear some discussion about what should be done with the cord. If you have an indirect inguinal hernia in an elderly gentleman where there is tremendous hypertrophy of the cremaster, which comes from the internal oblique, it can obscure and make repair extremely difficult. We mobilize the cord from the floor of Hesselbach's triangle to elevate it. The cremaster is opened, the cremaster is excised, and the cord preserved. I feel it's extremely important to identify the peritoneum, to clear it, and to accomplish a clean high ligation of the sac. If you instruct residents in this operation, you ask them to clear the sac, and then you can go in and clear anything from a ½ inch to 1.5 inches of sac. In the Houguet maneuver, the direct peritoneal sac is retracted laterally and converted into an indirect peritoneal sac. There is no attempt made with this maneuver to affect the attenuated transversalis fascia in the floor of Hesselbach's triangle. This is almost call it a little teaching gimmick. I find it's extremely difficult to have a resident identify the structures at the internal ring. Now, I call this triangulation of the transversalis fascia at the internal ring, and the fascia is picked up where it overlies the deep inferior epigastric vessel. Then, with traction at that point and a loop retractor to hold the internal oblique muscle upwards, one identifies the contiguous transversalis fascia, and at this point it comes downwards towards the iliopubic tract. At any rate, it's important to identify and close the transversalis fascia at the internal ring, and this is a simple method of accomplishing that. Now, we repair the floor by suturing what I call the fused parts of the internal oblique and transversus abdominis muscles. And we suture that down towards the inguinal ligament. I think it's extremely important to recognize that the layer we call external oblique fascia is rather simple of identification in this area, and so is the red muscle of the internal oblique. But when one gets to the fused parts of the internal oblique and transversus abdominis, this separation becomes quite difficult. Now, whether you want to call that a conjoined structure, whatever name you want to use for it, as long as you recognize what it is, I think you can accomplish the repair. Now, in a direct inguinal hernia, the relaxing incision we employ very frequently because we do a large number of direct inguinal hernias and becomes extremely important. We're very particular about closing the internal ring separately. The relaxing incision has a very interesting history. At one time, the sheath of the rectus was opened simply so that the rectus muscle could be brought down to Cooper's ligament or to the inguinal ligament. Of course, that has been found to be ineffectual because the muscle simply doesn't remain where one would like to put it. Many men have pointed out the extreme importance of a relaxing incision, particularly in the repair of a direct inguinal hernia. A part of the anterior sheath gives after a relaxing incision has been made vertically. It's made as close to the midline as you can make it. Now, I wanted to talk just briefly about sliding hernia because I think they are frequently over-repaired. One in which the sigmoid comprises part of the sac wall. This is the technique that I use. Nothing is original about this, but it's a technique that I prefer. The portion of sigmoid is delivered. The peritoneum is incised both laterally and medially. The medial and the lateral edges are brought together, and then the purse string suture placed. Finally, I would like to say that my experience with what one does with the external oblique has not been too important. Now, I had in the past transplanted a number of cords. I don't use this technique in thin people. It seems to be annoying to them. And as I've done more and more hernias, I've come to recognize that it's not of paramount importance what you actually do with the external oblique fascia.
The next speaker, Dr. Francis Usher of Houston.
The preceding panelists have emphasized the need of a relaxing incision so as to do away with the factor of tension in the repair. I think we're all agreed that that is probably the most important factor in any type of reconstruction of the floor of the inguinal canal. I would like to present to you a technique using a mesh of polypropylene in which we approach this principle from a different direction. Here we are using the mesh as a replacement graft to actually span the defect and avoid tension in this manner. The mesh is used quite frequently to reinforce a primary repair in which the conjoined tendon is sutured to Poupart's ligament, a Vicini type of repair, and the mesh is sutured over as a reinforcement. This does not do away with the factor of tension unless a relaxing incision is made in the rectus sheath, and we overcome this. We suture the mesh in a subfascial position beneath the conjoined tendon, the internal oblique muscle and transversalis, if you will, suturing the lower border to the shelving edge of Poupart's ligament. In this way, we do not compromise the area which has been occupied by the hernia. In other words, we do not create tension. Fibrous tissue grows through the mesh, and the transversalis fascia is now replaced by the plastic mesh with an ingrowth of fibrous tissue. This provides a very strong floor, and yet it does not create tension. The sutures are through and through sutures which are tied above the internal oblique muscles. A direct right inguinal hernia The usual oblique incision is made. The transversalis opened. The sac opened. Bowel extruding. We open the transversalis from the internal ring down to the pubic tubercle. The bowel content replaced, a high ligation of this direct sac accomplished. We always look for indirect sac present on this hernia. The epigastric vessels are severed and ligated. We do this whenever they get in our way. We do not do it unless we feel that they will get in the way of the implantation of the mesh. Forceps now grasp the upper cut edge of transversalis fascia, and the mesh will be sutured beneath the transversalis fascia, beginning with the medial border. This is a rectangle of polypropylene mesh, which measures about 1.5 by 4 inches. A little pledge that we no longer use. It was put on the suture to act as a stent for the suture on the superficial portion of the tissues. We now thread the graft on the needle, taking the upper corner of the graft. Polypropylene suture is the same material that the graft is made of, polypropylene monofilament. The sutures are tied as interrupted sutures. We place them about 3/4 of an inch above the free margin of the internal oblique and transversalis fascia, or conjoined tendon. One bite is taken through the upper border of the mesh. The needle is returned to be tied on top of the internal oblique muscle. These sutures are spaced about 1/2 inch apart, and altogether about 6 or 8 are placed in the upper margin of the defect. The technique is not difficult. The Ochsner clamps, or Coker clamps, the mesh is firmly attached to the under edge of the transversalis fascia. Now the medial corner of the graft is sutured to the pubic tubercle and to Gimbernat's ligament, or the lacunar ligament, by interrupted sutures. And the lower border of the graft is sutured by simple interrupted sutures to the shelving edge of Poupart's ligament. The cord retracted above. Now, 2 important sutures about to be placed. This will define the new internal ring. One suture is placed through the internal oblique muscle, comes out through transversalis, and will pick up the northwest corner of the mesh, and the needle is returned beneath the muscle and fascia with the aid of a knife handle, which makes a very nice retractor for this situation. And this suture is tagged and left long until another similar suture is placed below the cord. The second suture is placed just beneath the cord in the same manner and picks up the southwest corner of the mesh. The compass directions are given for Dr. McVeigh's benefit, since he is a sailor. The sutures are brought out. Once the 2 sutures are placed, the mesh is worked up underneath the cord. This provides an oblique exit for the cord and are cut. Recurrence at this newly created internal ring is very unlikely. Now the repair has been completed. The mesh spans Hesselbach's triangle, and yet there is no tension created. The cord will then be replaced over the mesh and the external oblique closed over the cord in the usual manner. We feel the application of this technique is mostly indicated in the direct hernias, the recurrent hernias, and the large indirect hernias, which essentially are direct hernias.
I'd like to ask a few questions. Dr. Ponca, do you recognize an incipient or industrial hernia on pre-employment examination?
Well, I think this is one of the most annoying things that we're faced with, this so-called pre-hernia. I have what I might call for myself minimum standards, and that is I either think it's a hernia or it isn't. And in my way of looking at it, it's an abnormal protrusion of a viscus through an aperture in the body parietes. Now, Some patients have a large dilated ring. They have a sort of a rotund abdomen, and if you get your finger through the ring, you can palpate the floor-vessel box triangle in some of these patients. Now, that, in my opinion, is not a hernia, and I don't recommend repair of that. Furthermore, I don't make with a diagnosis of a pre-hernia, because once you use the word hernia in the presence of a patient or in one of these industrial cases, you've had it. They become totally incapacitated. Yet we know that a small, direct inguinal hernia is a very insignificant threat to the patient to begin with. So I have my minimum standards in which I either think it is a hernia or it isn't a hernia. If it doesn't come through the ring, that is through the external ring, I do not call it a hernia. And I do not recognize in my practice this so-called pre-hernia.
We'll just go right down the panel, starting with Dr. Ponca. What type of suture material do you use, Dr. Ponca?
Silk.
Dr. Nias?
Silk.
Dr. Usher, when you're not using the Marlax mesh or suture, what type of suture material do you use?
Well, I have been using polypropylene for the past 6 or 7 years because it has been available to me. If I did not use that, I think I would want to use a more permanent suture than either silk or cotton. I'd probably use a braided Dacron suture. But polypropylene is a very excellent suture for this purpose.
How many knots do you put on the polypropylene suture?
3. Polypropylene monofilament has excellent knot retention, and 3 knots are so secure that it can be cut at the knot.
Mr. Moderator, I sounded awfully adamant about that. I don't think it makes a hoot what kind of suture you use, except I do not think you should use an absorbable suture. I think it's just a matter of, from your own experience, what you like to use. I know the boys keep handing me Tevdek and things like that, and just because I'm an old-timer in terms of silk, I feel good with silk. I know what it can do for me. But it has to be non-absorbable, and other than that, it doesn't make a hoot of difference in my mind.
I think that's the point I wish to establish. I think non-absorbable suture, whatever your preference, is certainly acceptable today. Then the question that is frequently asked, and in some brief way, try and describe it in order: how tight do you make the abdominal inguinal ring in your closure? Dr. Ponca.
As I've done more and more hernias, I've found that it really isn't too easy to make it too tight, and that I think in the years past I probably made them a little too loose. Now, in recent years, for very good reasons, I've become a little more conscious of the size. Now, if you could take your thumb or your middle finger and pop it through the internal ring, that's probably too large. What we do is take the so-called small curved hemostat and insert it in the ring, and if you can open it as much as a ½ centimeter to a centimeter, you have a sufficiently large internal ring, and that's about how snug we try to make it.
Dr. Nias, what's your gauge in the posterior inspection of the ring?
Well, we've been surprised at the facility of the posterior approach gives in terms of tightness of the internal ring. From the anterior approach, I used to be a little finger man and go in there, and that was about the right size. But now, where you're looking directly at the internal ring, you can, I believe, make your closure tighter, that the finger cannot be inserted into it, but you feel at ease because you put a hemostat in it, and you can feel the mobility of your repair, and there is plenty of room for edema if that's going to occur and so forth. So we don't concern ourselves so much about it because we're looking right at the internal ring and can modify our repair, as is indicated, around the skeletonized cord. I don't think enough emphasis has been made in the years past about getting rid of those lipomas of the cord, getting that cord down to a small size for a better closure of the internal ring.
Dr. Usher, I think you answered this, but would you just repeat as regards the size?
Yes, I use a large Kelly hemostat, and if that can be passed along the cord, I feel that my opening is sufficient. If I can get my little finger in it, I feel that it's a little too large.
I think these are good points. The ring must be made very snug because in anybody's series, there are a certain number that recur right through the abdominal inguinal ring. Conversely, if it's too tight, there is such a thing as atrophy of the testis. There are a number of questions here on anesthetic. Dr. Ponca, what's your choice of anesthetic?
I use local anesthesia in about 98%.
Dr. Nias, with your preperitoneal approach?
something that gives me relaxation. There's one thing you have to have from that approach, and that is you've got to have relaxation. We have done them under local, but it's kind of tough, and either general spinal is very good.
How about implanting your Marlex mesh, Dr. Usher?
I prefer either a spinal or a general anesthetic because we do need relaxation in order to implant the mesh beneath the transversalis fascia. Our anesthetists use general anesthesia more and more, I think about 10 to 1, which has proven very satisfactory.
I might take the moderator's prerogative to comment on this. I think everyone should become familiar with the use of local anesthesia for 2 reasons. One of them is, when you're operating under local anesthesia, you can ask the patient to cough and see how your repair is coming and see if there's any tension. It gives you some insight, and if you've never done it, you try it, you might be surprised what a good strong cough will do to your repair. Secondly, I think no patient, irrespective of his age or perhaps otherwise debility, should be denied a hernia operation if it's bothering him, and this can be done under local with practically no risk and certainly very low morbidity. Now, one question that's been repeated 3 times, and this is always a good one. In an infant with an indirect inguinal hernia on one side, what do you do about the other side? Dr. Ponca.
If there's no hernia, I do nothing about the other side.
Dr. Nias.
Now, I tend to do exactly Dr. Ponca. The problem comes up because if you explore the other side when none is visible, you'll find a sac in a high percentage of situations. However, it has been found by study that knowing this, in those series where they haven't repaired these, that a much smaller percentage will develop a hernia. So actually, if you do both sides under this setting, you're doing a lot of kiddies an injustice.
Dr. Usher, opinion?
I no longer explore the contralateral side. I think that you do possible cord damage, and my yield of hernias on the opposite side has been so few that I have given it up.
Excuse me, gentlemen, momentarily, to say that this doctor concludes this side of your reel. The remainder of this program on the surgical management of groin hernias may be heard by simply reversing the 2 reels or cassette cartridge on your tape recorder. This is Side B, Audio Digest Surgery, Volume 16, Number 18, continuing a program on the surgical management of groin hernias. Resuming his questioning of the panelists, here once again, our program moderator, Dr. Chester B. McVeigh.
I'm going to group a number of questions that have come in here because they all ask the same thing. It has to do with ligation and section of the cord at the time of inguinal herniaplasty, and do you feel that it adds to your repair? Dr. Ponca.
Over the years, I have not taught anybody, for instance, how to remove the testicle, because this seems to be something they already know how to do when they come into the operating room. So I try to teach how to preserve it, and this is my effort. Now, as far as sectioning of the cord goes, I don't find that necessary. If you embrace the principles that you've heard expounded here, I think you can repair the hernia and leave the cord in place.
I don't believe that in a primary repair that it should ever be done. And unfortunately, that's supposedly when you can do it without any trouble. You know, if you don't remove the testicle from the scrotum in a primary repair, you can supposedly go, you know, and cut it right in 2, and there's enough collateral coming through well-documented vessels from the scrotal area to take care of things. But unfortunately, when we all get a recurrence from somebody else's case, we don't know whether or not they pull that testicle out and destroy these collaterals, and therefore I would be very leery about doing this unless I knew exactly what had happened at the primary repair. I agree, too, that I think we must, except in the 10-time recurrent patient where the patient's 83 years old and it probably doesn't make too much difference, to get the okay ahead of time, I would consider it there. But I would say never in primary repairs would I consider transection of the cord, even though I think you can get away with it anatomically.
Dr. Usher?
I certainly agree with Dr. Neus, and even in the recurrent hernias with a little careful dissection, the cord can be preserved. Now, frequently in a recurrent hernia, the vas will be somewhat separated from the cord vessels, and inadvertently you may section the cord. In that case, of course, you just tie off both ends and proceed. But if you can preserve the vessels of the cord, I think that it should be done. I do not think you should section the cord in order to make a snug closure of the internal ring.
I think that's a fair statement of the problem.
What about in a woman? I kind of like to know what the panel would do with that round ligament. Do you just whack that and close it up tight, or do you try to preserve that, Dr. McVeigh?
Well, I'll ask you. What do you do?
Well, I've been in the sort of a habit of cutting it and letting it fly and making everything real tight.
Other panel members?
It's an interesting anatomical fact that the direct inguinal hernia is extremely rare in women, so that in my experience the hernia is usually indirect, and the round ligament doesn't carry the same physiological importance in the female. It has to do with holding the uterus forward, perhaps, especially at the time of pregnancy. But the sacrifice of the round ligament in the female, I don't think is quite comparable to the sacrificing of the entire cord in the male. I don't hesitate to divide the round ligament.
I think that's the correct answer. If you try to separate the hernial sac from the base of the round ligament and do a high ligation, you're into the peritoneum of the broad ligament, and you get into holes you cannot close. And so I think it's pretty generally accepted that you handle the round ligament with the hernial sac in the female. There are several more questions came in, so it must not be clear about transecting this cord. I think the opinion of the panel was, don't transect it. There's rarely a reason, except for the mutilated cord in recurrent hernias, and I think it's safe to say if you do not disturb the cord beyond the pubic tubercle in a recurrent hernia, the collateral circulation will keep it viable. On the other hand, most cases, this testicle then swells to quite alarming proportions and then gets startlingly small in the period of the next year, but it does not slough. Dr. Usher, do you do an appendectomy at the time of a right inguinal herniaplasty as an incidental procedure?
Only if the appendix presents itself and it can be accomplished easily technically. I do not fear contamination from appendectomy, but I do fear complications from trying to draw down the cecum or remove the appendix under tension.
The other members of the panel agree with that statement?
I agree completely. I think that if there's any aspect of complication to your repair, that it's a recurrent hernia, particularly multiple recurrent, or something's gone awry with the procedure of a minimal nature, I think you should leave the appendix alone. But if everything's going well, it shows up, says hi, then we should probably go ahead and take it out.
Now, we have so many questions that all lead into the same thing. One of them is, what do you do with the long hernial sac? Does it make a difference if it's a child or an adult? Dr. Ponke, do you always remove the indirect hernial sac?
Well, I prefer to remove the sac, although it's not absolutely necessary to remove it in its entirety. What I try to do, at least, is to prevent the formation of a sac distal to the point of transection. Now, early in my career, I was taught that this wasn't necessary and that you could ignore that part of the sac. And after seeing some people come back with scrotal swelling and a hydrocele remnant there, I decided that I was going to pay a certain amount of attention to that distal sac. Now, what you can do to it is open it on the side away from the cord. In other words, split it longitudinally if you do not wish to excise it in its entirety, and evert it about the cord. Now, this has to be done with some care, but it makes a very satisfactory disposition of the distal sac, and in my experience, that's eliminated this hydrocele remnant that can give us trouble.
Dr. Neus, how in the world do you pull a long indirect sac from the retroperitoneal area?
Well, we do exactly like we did in the olden days when we did all our repairs from the anterior approach. I consider it in a child very bad to dissect out hernial sacs. We're talking about scrotal sacs. Naturally, those that are down in the inguinal canal come out readily. But I think that to make a big deal out of getting all that sac out of there is wrong, particularly in children, but it's really worthless procedure in adults. And therefore, if you remember, transect the sac, do your high ligation, and are certain that the distal opening is open so that material can drain out of that sac into the tissues, the incidence of, quote, hydrocele, unquote, swellings is, I think it's less than 1%. And if you do get a swelling, usually one aspiration will handle it and it doesn't recur.
I think Dr. Usher and I would agree with that.
May I add one point?
Yes.
One objection to removing the sac is that you produce a lot of bleeding from small vessels that are opened in the dissection, and you're more apt to get a hematoma of the scrotum. I think that is one of the chief arguments in adults for leaving the sac but opening it widely.
I think one must be very cautious in doing infant hernial surgery about not disturbing the testis and the scrotum, or you will have a high incidence of atrophy. Dr. Ponca, do you always open and remove the sac in a direct hernia?
I open the sac, I pick up the peritoneal prolongation at the internal ring. I don't open directly into the floor of Hesselbach's triangle for the danger of getting into the bladder. So I do open the peritoneum at the internal ring and convert it into an indirect sac by the Houguet maneuver.
Dr. Nias, do you have any objection to transfer of the stump of the sac under the internal oblique?
No, don't worry about it a bit. If that's what you like to do, do it. If you don't do it. I don't think it makes a hoot of difference, again, how you handle that.
This was a very popular technique a good many years ago of taking the sac and after you've ligated it, leaving long tails and bringing it up through the internal oblique. I think this served as a fixed point, and at least personally I've repaired several hernias that recurred at this point, probably from pressure necrosis of the suture that traversed the transversus and internal oblique.
The important thing, of course, is stress is the high ligation of the sac and the plastic to the internal ring on those small hernias, and what you do with that, as I say, is not important at all in my mind.
This is a specific question to Dr. Usher. How do you manage infection if it occurs in the mesh? Dr. Usher.
In the first place, the wound complications with the deep emplacement of the mesh have been no greater than in primary repairs. We've had infection in 4 of 263 cases. When you do get infection, the proper procedure is to simply open the wound widely and drain it and treat it with wet dressings and the specific antibiotic as you would with any wound infection. Now, if you have used the monofilament sutures, the wound complication of a draining sinus is very unlikely. If you do get a draining sinus, frequently it is limited to just that small segment of the mesh that has a suture in it, so that it is not necessary to go in and completely remove the mesh.
Dr. Ponca or Dr. Nias, do you have any experience with the mesh?
We've been purists in our work in terms of seeing what we could do without any foreign material. Dr. Usher, I feel quite strongly that these types of materials should never be used on a primary repair. Now, Dr. Usher has a very real right to run a series and to try this in direct hernias, because you know that the recurrence rate for direct hernia is at least 15%, I really believe, except in the hands of people like McVeigh and Ponca and Usher. But I don't think that in general that we should be rushing to do direct hernias with a primary repair. Now, as far as I've gone on this, is that whenever I have a huge breakdown of the groin wall or in a huge ventral hernia, I always tell the girls, have some of that Usher stuff ready to go, because I do think that sometime I'm going to run in a case where I have to use it, but so far I have not.
Dr. Ponca?
There aren't many people in this audience that haven't seen the complications of infection in the groin following a hernia operation. Now, the mortality rate isn't 0 from hernia repair, and neither is the infection rate 0. So that all you have to do is do enough of them and you're going to see this. Now, if you use silk and the organisms get into the braids, you can treat them with antibiotics until Hades freezes over, and if you've gone as far as a heavy silk suture, sooner or later, either that silk is going to have to be spit out or you're going to have to get it out. Now, this means that you should treat these patients with antibiotics, and usually the organism is a staphylococcus. And if you're not careful, it might be one from your skin instead of the patient's. That is a puncture of the glove. This is something you have to be very careful in the operating room when you're having younger surgeons operate. They handle the needle with a little abandon, and it's not hard to do. They perspire and inject this into the wound, and it's not a difficult thing to have happen. So after you treat them beyond the primary phase, that is, you get the redness, the swelling, and you've drained the wound, and you get this cooled down, they still have a little punctum there that continues intermittently to drain, and I don't care what antibiotic you use. Eventually, one way or another, you're going to have to get that out of there. Now, it is true this doesn't happen very often, but this is something you don't need many of.
Just an additional word, perhaps my practice in later years is a little different. I see many multiply recurrent hernias. I would just like to report support of the preperitoneal approach plus the Marlax mesh in some multiply recurrent hernias. It isn't exactly easy because of the dense scarring, but I'm sure Dr. Usher would agree that in using the Marlax, it should be placed deeply, and when you're in the preperitoneal space, it is deeply placed. And I've had, in several occasions, I think, a very happy result from placing the Marlax by the preperitoneal route. Dr. Usher, do you recommend irrigating the wound with saline and an antibiotic solution, either with the mesh or without it?
I like to irrigate the wound in any laparotomy. I do not use the antibiotic solution unless I have a ruptured appendix or a ruptured gallbladder with purulent contamination. But I do think that irrigation of the wound in an inguinal herniorrhaphy, as well as other elective surgery, adds up to the toilet, to the cleaning up of the wound.
Several questions here. How do you manage the hernia repair in the face of gross contamination from a strangulating obstruction? Dr. Ponca.
Well, I've looked over our results in femoral hernia, and this has been a rather interesting experience. The incidence of infection in this situation is remarkably high. Now, I'm speaking now of the type of hernia where the intestine is caught in it and more or less compromised. For instance, in some of them, the bowel is actually dead, and in one, there was actually pus present. This is what we're talking about at the moment. Now, in this situation, I would go to wire, and I would leave the wound rather loosely closed without trying to get a real tight approximation. But I would go to wire rather than anything like silk, for instance.
I would go to wire. How about Dr. Usher? Is your Marlax is inert as monofilament wire?
The monofilament polypropylene is, I wouldn't say immune to infection, but it has the same advantage of monofilament wire. And I think that in the presence of infection, it's particularly indicated. That's why I prefer to use it over a braided suture with the use of the Marlax mesh.
I think the management of any contaminated wound applies exactly the same to a hernia repair. And if you ignore these principles, you're going to have massive wound infection and inevitable recurrence.
There is a technique of Dennis and Barco where they isolate and remove all this dead stuff so that you do not contaminate the wound, which is a technique I think we should all read about and be aware of. The Dennis technique for isolation of your necrotic bowel away from your wound so that you don't contaminate the whole area.
Dr. Ponca, if you have a recurrence of a hernia in 1 or 2 weeks after surgery, how soon would you go in again?
That could be repaired any time, but
you don't have any experience in that, do you?
I would hate to think that that had happened very often.
I might just remark, when that happens, it's usually a missed hernia.
Right. That's right.
I would just like to say a few words about interpreting your results, because I think this is fundamental for each of you and each of us to evaluate what we have done and what we are doing. Now, very fundamental is to distinguish between the types of hernia that you are repairing. In other words, categorize them as small to medium indirect. You can lump the large indirect and direct together because they present the same anatomic problem, and then the femoral. Now, the reason I mention this is because A very excellent result in a group of hernias, the small indirect group, can obscure a perfectly appalling recurrence rate in the so-called difficult or large inguinal hernia. There are many studies to prove that if you simply remove the hernial sac in the small indirect variety and don't do any damage in the process, whatever you do after that probably is of little consequence. Now, a number of years ago, we reviewed the first 100 recurrent hernias that we repaired, and in this I learned a lesson. The man who reports his hernia recurrences from 1 to 5 or 6 years is not reporting statistically valid material. For instance, in 1 year in this group, 21% recurred. 1 to 2 years, 20%, 2 to 3 years, 10%, and from 3 to 5, 11%. So it's true that the majority will recur if they're going to by the end of 5 years. But now, from 5 to 10 years, 19%, 10 to 15 years, 9, 15 to 25, and from 20 to 25 were 5 in this group of recurrent hernias. So complacency in the results after a few years is unjustified. Dr. Diaz, with your approach, what is the incidence of wound infection in the group with intestinal resection, and what is the % of repair breakdown?
What we've been particularly astounded at is the low overall wound infection rate. We were concerned about this early because you open up a large space which is not serosal lined, etc., and we've been pleased to find the lack of wound infection per se as a problem. I think in the state of incarceration, strangulation, obstruction, that our wound problem is exactly the same as it from the anterior approach. I'm glad someone asked about the recurrent rate in our series of over 1,000 cases, followed, I must admit, for not 20 years, but averaging 5 years. For primary repairs, it's about 2%. When you talk about operation for recurrence, the recurrence rate in that group is 6%. The overall recurrence rate is 3.5%, bunching them all together. I am concerned about the number of recurrences and people who are in private practice who say they've tried the repair on 3 or 5 patients and they practically all recur. I don't know what to blame this to. The people who are in practice that have gone through my program, for example, continue to use it almost routinely, and I'm pleased with that. But I am concerned that unless someone has taken the time to go to the anatomy or go to the autopsy room and study the anatomy, that there's too much trouble. So a word of the wise is sufficient. If you're going to use it, study it. Don't just say, oh, it looks good on paper, I'm going to try a few, because I think you'll get into trouble. The anatomy from the backside looks entirely different than it does from the anterior approach. Talking about recurrences, Dr. McVeigh, I would like to ask you a question, and the panelists. You said that after 20 years, there's a certain incidence of recurrence, didn't you?
Yes. In this group, 5% recurred in the years 20 to 25 years after their first operation.
Right. Now, I can envision that a number of patients who I did a beautiful operation today and did a plastic to the internal ring, which was a congenital problem in the first place, and I did that well, that when they become 70 or 80 years old, they then get a classic old man's hernia of a direct type. Now, I don't know who to blame that new hernia on, unless probably these techniques that we're espousing. If you did a Bassini or a Halsted where you layer things and cover that direct area routinely, then I would say it was a true recurrence. But in the type that we're talking about, where we don't touch the Hesse-Box triangle if it isn't diseased in the young person with an indirect hernia, I'm afraid that we're going to get a few new hernias, and I don't want you to call them recurrence.
Dr. Usher, you're wiggling your finger at me.
Dr. McVeigh, I think one possible cause of these late recurrences may be overlooking an indirect sac at the time we repair a direct hernia. Frequently, the surgeon is so enthusiastic over his discovery of the direct hernia and his reconstruction of the problem that he does not skeletonize the cord at the internal ring and look for a small indirect sac which may be present. If that sac is left, then in later years it may well develop into a so-called recurrence. I've been guilty of this myself, and I think in every direct hernia, before you start the repair, you should take a very careful look at the proximal portion of the cord to be sure that there is not an indirect hernia present.
I would reemphasize that point. In our own series, when we last analyzed it back in the 50s, almost 10% of the hernias were multiple. That is, the indirect had a direct component or a femoral or vice versa. So this is very common. I would say this: if the hernia recurs rather promptly, you've probably missed a hernia. If it recurs, and in our experience, any time after 8 years as a direct hernia, we then get into the point that Dr. Nias is discussing, and that is old man's disease or weakening of the aponeuroticofascial structure. However, I think to be perfectly honest, we must call this a recurrent hernia because I think it's incumbent upon this operating surgeon to evaluate the strength of this posterior wall at the time he's either doing a femoral or an indirect hernia. And I must admit my judgment has not always been excellent in this regard, but I think this is the obligation of the surgeon to make this decision. And if he's wrong, and 10 years later the patient has a direct hernia, I think it is the surgeon's fault, and he should have done something about it in the first place. There are several questions here about the cause of recurrence. I think probably we've discussed that. I would ask Dr. Ponca what he thinks the fault is in the repair of a small indirect inguinal hernia when it recurs as an indirect inguinal hernia.
I think there was failure of closing the transversalis fascia at the internal ring. I think you must get a high ligation of the sac, you must identify the transversalis fascia and close it accurately.
I think in this same context, it's well to mention what I believe Dr. Nias mentioned, and that is to be sure there are not protruding processes of preperitoneal fat. These may be multiple. And to leave them passing down through the ring into the cord is asking a recurrence because the continuous pressure, increased intra-abdominal pressure, acts as a battering ram. This is the old lipoma theory of Cloquet for other types of hernias, and it'll cause a recurrence. You might be interested to know that 2 of our recurrences at the abdominal ring had to do on the left one with catching an epiploic appendage in the closure and fixing it there. The other side was a knuckle of cecum caught in the closure of the ring, and the reason I know this, these were the leading structures in the recurrence of the hernia. A number of questions here, and we'll just poll the panel. What is your recurrence rate, Dr. Ponca?
I tried to do a study on this, and I wrote some letters to several of the employees of the various companies, and this got so complicated that as a matter of self-protection, I had to stop it. For instance, the patient would wonder why he was being recalled, and if you found a hernia on the opposite side, you'd get into trouble with this because you'd have to notify the company and you'd have to take steps to correct the thing. So I can't give you a hard figure. I think for indirect hernias, my recurrence rate runs around 1%, and for direct around 3%.
Dr. Usher.
Of 263 cases with a follow-up of 1 to 10 years, the recurrence rate has been 3%. Now, this rather modest number of cases, 2/3 were direct hernias, and 1/4 of the group were recurrent 1 or more times. I feel, as you do, Chester, that the simple indirect hernia should be treated with high ligation of the sac and plastic closure of the transversalis fascia at the internal ring. So that, as I think I mentioned before, I believe that the use of the mesh in the repair of these hernias is largely indicated in the direct and the recurrent hernias.
My information is published. I won't add to that because we are in the process of doing a 20-year follow-up on some 1,200 hernias. I think the recurrence is going to be about the same as it was reported in 1956, and this varies between 1 and 2.5%. It seems inescapable that we can't be perfect, but certainly anyone doing a series of hernias, if his recurrence rate gets over 6 or 7%, he'd better examine what he's doing.
Thank you, gentlemen. And our thanks, too, to the Council on Scientific Assembly of the American Medical Association for cooperation in recording and disseminating this material. Your next issue of Audio Digest Surgery features a bare-knuckle analysis of the surgeon and malpractice, with an all-star medical legal faculty made up of F. Lee Bailey, Melvin M. Belli, Bill Coulson, Raymond J. Dwyer, Samuel J. Powers, Jr., J. B. Spence, and Carl E. Wasmuth. This upcoming issue will be sent to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over a 52-week calendar. And, for now, this concludes this edition of Audio Digest Surgery, produced twice each month by the Audio Digest Foundation as a non-profit subsidiary of the California Medical Association. All material in this program is copyrighted, and further tape duplication is prohibited.